I say give it one more minute and then let's get started because we've got a full agenda.
Yep. Hello, Leslie. Again, we were just in a meeting together.
Hello.
Okay, Sunday, I think let's get going. There may be more people who join us.
Sounds good. So as we always do, we're just going to start with some brief introductions because we do have some new faces. I will start. So I'm Sunny Schneider. I am a police officer with the City of Waukesha PD, and I am part of a co-responder unit and one of the facilitators for this work group. Sita?
I'm Sita Deal. I'm a co-facilitator of this work group and a NAMI volunteer and a member of the Mental Health Action Partnership core group.
Jim?
I'm Jim Satomsky. I'm on the NAMI board, and I work as a behavioral health educator at Waupun Correctional Institution.
Rick?
Good, I'm unmuted. Rick Schultz with Admire in Milwaukee. I'm here because of my role as a dad.
And our new face, Mr. Schaefer.
Howdy. So my name is Amaya Schaefer. I honestly was just seeing the emails from you guys sent to my PD, and I had some free time. I came in early. Only my chief is in at this time, so I figured I'd swing in and see what it's all about. But I get to learn something new. So, of
Thank you for being with us.
course.
And then we got Cartwright.
I'm Heidi Cartwright. I'm the detective lieutenant with the Shawano Police Department.
Excellent. Thank you. Josh.
Hi, everyone. I'm Josh Hopkins. I'm the behavioral health investigator with the Outagamie County Sheriff's Office.
Caitlin.
Hi, I'm Caitlin. I am the Greene County Crisis Case Manager.
Leslie.
Hi, Leslie Fox with the Dane County Sheriff's Office. I'm one of the mental health deputies, and I can't get my video to work right now, just FYI.
Thank you. Mike. You there, Mike? We'll come back. Pete.
Hi, Pete Christensen with the Admire Family Grassroots group here in Milwaukee, and good to see all of you, especially new police officers.
Yes. Mike, are you with us yet? Doesn't look like it. Let's go, Ryan.
Yeah, good. So I'm Ryan Fox, Chief of Police for the Plover Police Department. I'm also the president, Central Chiefs Association here in Central Wisconsin. So about 68 of us chiefs. And I see a couple. So I've been putting emails out to our group of chiefs, and that's why you see a couple of new people from Shawano PD jumping on today. But I'm more of a silent observer of this group, but I'll give you input whenever I can.
Thank you for being with us, sir. Sandy.
There we go. Sandy Schultz with Admire in Milwaukee, working to help make things better in Milwaukee County.
Thank you. Tom.
Hi, everybody. Tom Parr, Membership Director for the Wisconsin Veterans Chamber of Commerce and retired cop from City of Madison Police.
Excellent. Kendra.
Hi, I'm Kendra Carter from the Ozaki County Sheriff's Office, a behavioral health deputy, part of a co-responder unit.
Zach.
Zach Bosch, Corporation Counsel in Waukesha County, Assistant Corporation Counsel.
Mike, are you there? I'm not thinking he's
Mike Mooslauf is the chief of police for the Shawano Police Department. He apparently does not have a microphone or a camera enabled on his computer.
No worries. All right. Well, thank you for being with us, Mike. Did I miss anybody? Oh, Dominique's here.
Hey, we made it. As you probably know, Sunny, we were just on another meeting.
Yes.
So I'm actually here with Emily. I'm the program manager here at NAMI, Wisconsin, and I'm here with Emily Smiley, our program director. She's right next to me. So we're both here. Hello.
Hello. Thanks, guys.
Nice to see everybody.
Yes. Did I miss anybody? I think we're good to go. Great. Well, as usual, I've got multiple computer things happening here, so don't pay attention if I'm not looking at you. But thank you guys so much for being with us. We do have, we've got kind of a lot of work to get through today. So as usual, please just raise your hand if at any point in time, if there's something that you want to say or to contribute or anything like that, just raise your hand. And we're going to be going through, the majority of the time is going to be going through what we presented at the last MHAP summit. But to start, Sita, you want to talk about the panel that we saw?
Yes, at the MHAP Summit, the Mental Health Action Partnership Summit, which was held on September 10th in Madison at the Central Library, just a block from the Capitol, we had a legislative panel which included the two chairs of the respective Senate and Assembly mental health committees. So Senator Jesse James from Chippewa Valley and Representative Paul Tittle from Manitowoc. And then Senator Sarah Kieski, who is a new senator from the Columbia, Richland, a kind of rural west area. She is a therapist. And so she came in, partly with that mental health agenda. And then Rep. Robin Vining, who is from the just outside Milwaukee area. And she has been a mental health advocate all along, particularly for school-based mental health services and the mental health workforce. They were very informative. It was at least as useful for them to see us gathered because there were over 70 members of the mental health community gathered, everybody, peers, family members, providers, county people, hospitals, some law enforcement. It was just a wide swath of the mental health community. So I think it was important for the legislators to see that we were talking amongst ourselves and that we do have an agenda. We gave them our near-term priorities and asked them to speak to them, which did. And Senator James was in, telling it like it is, which we respect. And so he said, we did our best with the budget. It was a difficult circumstance, considering that the what was happening at the federal level, and don't expect much if it is budget related. If it isn't in the budget and it needs money, don't expect the bills to pass. That said, there are a couple bills that just came up for this week that we want to discuss with you. So there is legislation that is moving in this session, and some of it is on our agenda. I think there's a lot of back and forth, or some back and forth in the room, and then a lot of back and forth out in the hall as MHAP member organizations buttonholed the legislators. So it was really valuable.
And it was pretty well attended, right, Sita? I mean, that was I think the biggest group that we've had so far, so which was great.
Yeah, yep.
Really great. Actually, do you mind? Can we just knock out the two bills and just talk about those, Sita?
Yeah, sure. So I'm going to put these in the chat. Assembly Bill 447 has just been introduced, and we would love your feedback on this, particularly those of you who spend time in the courts and those of you anybody who has been an expert witness. It allows court discretion to use video conference for expert witnesses in certain hearings, such as criminal, civil commitments, and protective placements. So does anybody have an opinion one way or the other about that right now, if the defendant objects, then there can be no video conference. If the so this bill, even if the defendant objects and the court uses their discretion to say, no, we really need to bring this person in, the court can override that objection. Are there thoughts about that? At least that's the way I understand the bill. Maybe someone else has a different understanding.
Like I said, just raise your hand in the thing. Yep, Zach.
This is great news, in my opinion. One of the difficulties that I know every county is facing right now for the court aspect of commitments is a lack of doctors that are available. We have less and less psychologists and psychiatrists that are willing to take these cases because these cases don't pay much and they take a lot of work. And so we're having to go further and further out from our kind of central core of our county to find more doctors. And one of the barriers to that is that if they have to come in person, that's an additional cost, and a lot of counties don't pay for that cost. So the ability to be able to have them testify by Zoom, they're experts, there's some element of credibility to them, especially if they are routinely appearing in front of a court. You know, with our video capabilities these days, I don't see how there's any question about the credibility of the witness being by video on a giant TV screen in the middle of the courtroom versus having them on the stand. And after going through COVID and having a lot of Zoom hearings, we had to do it that way anyway. So, you know, I don't see that this is a bad thing. Certainly other people can disagree, and I certainly understand some of those arguments on the other side. But from the county perspective of trying to get these commitments and trying to find qualified expert witnesses in terms of doctors, this is a great step, a great, easy, non-budgetary item that we can do.
Thanks, Zach. That's the way I was reading it. Does anybody have a different opinion? Okay, well then we'll register in favor, and we'll give the reasons why. And then the second one is an old bill. This has been introduced at least 3 sessions, and it would expand the treatment alternatives and diversion expansion expand the treatment alternatives and diversion program to include programs that serve people with serious mental illness, such as mental health courts. And Officer Hopkins and a small group of us wrote a issue paper in favor of expanding TAD, and we wrote a sign-on letter in favor of expanding TAD. So that sign-on letter, so this bill is coming up for hearing, boom, tomorrow in the Assembly Judiciary Committee. So the fact that we have done this background work is putting us in good stead, because we have a well thought out response that we can just send to the committee and register in favor of TAD expansion. So NAMI Wisconsin is going to submit on behalf of MHAP tomorrow, and we'll register in favor, and a lot of organizations have registered in favor of moving this bill forward. And anybody who would like to submit either written or in-person or video testimony, I'm going to put the name of the staffer, Nick Schultz, in the chat. You can send your testimony by email to Mr. Schultz, and it will be included. It should get there by 4 o'clock today, if you want it included to be included in the testimony tomorrow. So there are 3 ways to testify. One is simply to submit written testimony. One is to go to the Capitol and sit there in person and just take your knitting. That's what I'm saying, because it takes a long time. And then the third one is to appear on video conference.
What is the bill number again for the TAD expansion?
AB 178.
And that should be in the agenda too that you kicked out, right, Sita? So you guys can see.
I believe so. Yeah,
Yep.
in the updated agenda, it's kind of, all of this is late breaking news. So
Nice.
yeah, I'll put that in the chat as well.
Cool. Any other thoughts or feelings about those 2 bills before we move on? No? All right. Then What we wanted to do was review some of the midterm priority that we identified as a group, which was how do we reform 5115 emergency detention process. And CETA, I don't know if we're able to pull up the actual document. And this is what we presented at the last MHAP session. We just kind of picked, some highlights throughout the process because as you'll see, if you haven't looked at it already, it is quite the beast of a document. There's a lot of opportunities to learn about things that are going really well throughout the states with this process, but then also things that are obviously pain points and not going well. So this document that CETA is putting on here, it looks like is the green all the kind of feedback that we received then, CETA?
Yeah, the green is the new feedback.
Excellent. So how this document was laid out is, and actually, CETA, are we able to show the circular graph to start?
Yeah.
Is that possible? Thank you
Yeah,
so
here
much.
it comes. Hang on just a sec.
Thank you. This was something that we had put together to try to understand, and this is not all encompassing. So by all means, if at any point somebody's like, yeah, you're really missing the ball, there's this whole other area, raise your hand, let's talk about it. But initially what we had put together is a graph that goes in a circular fashion, talking about, there we go. All right, and we'll have to make it big. So if you look at the darkest, the darkest box, it starts with crisis prevention. So ultimately, our thought is before we even get to a 5115, how do we keep people stable so that we don't need to go that, right? That's most restrictive is to do a 5115. I think anybody you talk to starting with crisis prevention. From there, it goes into early intervention. So right, maybe that looks like a co-response team is visiting with that person in their home. We're getting them additional resources. Again, not a 5115 yet, but there's some resources provided. From there, then we go to initial call to dispatch. Where
Honey, I'm gonna stop share because I can share a larger looking version here, I think.
Oh, fantastic.
Just a sec. Yeah.
Yeah, there's a lot of points. And like I said, when you're looking at this wheel, if you're saying,
is that better?
Missing something, I think so.
Okay,
yeah, everybody's nodding. Okay,
go
great.
ahead. Yep.
We've got initial call to dispatch, then we have crisis assessment. So crisis assessment, whether you got a co-response or not, doesn't matter. In every place but Milwaukee County, we know officers are not allowed to authorize this. We need a crisis clinician to authorize. So we have them coming in, doing their assessment. Then we have a transport to the ER because we need to initiate that med clearance once the 5115 is approved. What we've learned is that in some cases throughout the state, it's not as clean as crisis coming to the scene and evaluating. Sometimes officers have to get them to the ER, which is why you'll see ER evaluation. So there's different points in this process where crisis can get tagged to come in and do the evaluation. So you'll see some back and forth there. But assuming that the 5115 is approved, we're going to move into, that's what that emergency detention portion there is. Then we know we have to get medical clearance because most psychiatric facilities do not have the capability of treating folks medically. And also there's conditions such as UTIs, which can appear as a mental health condition, but really it's a medical, right? So that's why we have that part. From medical clearance, we move to doc. So that's the hospital staff talking to the psychiatric staff to figure out what they need to get that placement through. Then there's the psychiatric hospital that has to go through their accepting or rejecting of the process. Transport, typically this is law enforcement doing the transport to that psychiatric facility, whatever it is. The custody transfer, then there's up to 72-hour hold process, the PC hearing, probable cause hearing for, corporation counsel to look at maybe there's a settlement agreement or commitment, maybe not, maybe it's dismissed, right? But there's that process. Then there's the community services. So all the outpatient or even like partial inpatient stuff that still may be on the table depending on how it shook out. These are kind of like the main steps in and around the 5115 process that we've identified so far. Rick.
Unmute.
Yep.
In that circle, I do not see where Chapter 51 is initiated.
As in approved and you're in custody.
I believe there should be a box there that says it started right here.
So that we were thinking was the one that said emergency detention, but we could say emergency detention approved to be more clear. Would that be better?
You know the circle better than I do.
Okay.
But what you think is best, when you were talking, you talked about the crisis assessment by a social worker, and then you talked about the Chapter 51 right then and there. Just looking for clarity, that's all.
Yep. So, and it is confusing because when the chapter gets approved, it can look different. There is no clean linear process, so it is a little bit confusing. Like I said, there's times where officers, if you have like a co-response, for example, a clinician on scene in that person's home can say, yep, chapter approved, and then we're going to the hospital for med clearance and so on. But there's a lot of places throughout Wisconsin, which we've learned, where the officers have to get that person just for that assessment to the hospital. Then crisis is doing an assessment. So it's not clean and linear, I guess is the message. But we can make sure the emergency detention, CETA, help me remember, let's just say approved, just to, make that super clear. Anybody else have comments, things you think are missing, things you want a little bit more clarification on? No? Okay. So then going back to what we actually presented to MHAP, I'll give CETA a second so she can pull that back up. Looking at the crisis prevention. Hold on 1 second. One of the presentations that we had done as a group here is catch plans. So when you look at this graph under phase, right, crisis prevention phase, so we're thinking crisis plans, AKA safety plans, AKA catch plans, right? There's different names that these things get called. It's a lot like a psychiatric advance directive, where essentially this person who is voluntarily participating, these things are not forced, and the person has to agree, but it looks like developing some sort of plan where the person can say, yep, if I'm in crisis, I would like you to contact this person and that person. These are the sorts of things that you can say to me to build rapport. I prefer to go to Rogers rather than Winnebago. They can tell us kind of what they want. A lot of these would also include a release of information to cue in law enforcement if they're comfortable, so that all the information can be shared across there. So there's issues. What we tried to do with these graphs is to highlight the pain points or the issues with this and what would be an appropriate best practice potentially. So that's the effective practices and comments. So when you're looking at this, that's kind of how it flows. We were hopeful that the group would have reviewed this before meeting today. It's okay if you didn't, but is there anything that anybody has a comment on initially with this section that you, again, good, bad, whatever? Okay. Rick.
Sorry,
No?
I don't want to be that guy.
Be that guy.
You mentioned in the very first page PADs.
Yeah.
We don't have PADs in Wisconsin.
So, CETA, do you want to talk about that? So, while she's waiting, I will tell you this. Dr. Thrasher, who sometimes joins us, he talked to us about, and I don't know their exact names. Maybe you do, CETA, but we are looking to get a better version of this going. Go ahead, CETA. I see you're unmuted.
Yeah. So what we have in Wisconsin, and Zach can fill in the details, is we have health directives, health advance directives, and those must have an agent. So the person must name an agent, a person that they trust, to make healthcare decisions for them. And so they're not specific psychiatric advance directives, as is the best practice out of North Carolina. A couple of disadvantages with the Wisconsin psychiatric advance directives is that they are revocable at any time. So the person can be in the middle of a crisis. Part of the point of this is that you make decisions in advance. And then if you get to a point where your judgment is being questioned, they can look back at this document and go, this is what the person said when they were making good decisions. So the fact that it's revocable at any time undercuts it. It means that the person can say, no, I don't want to use this plan in the middle of a crisis. And then the second disadvantage is that the agent may not direct the person to be hospitalized or to receive ECT or any kind of, what they call drastic treatment. So particularly the hospitalization is a problem. Zach, do you have any further information on that?
Yeah, I mean, our healthcare power of attorney documents in Wisconsin are really meant for healthcare, not psychiatric care. And that's a barrier in and of itself to the issue. And I agree what Sita said is the person can revoke that healthcare power of attorney at any point, whether they're competent or incapacitated in some fashion or not. And that creates an additional issue. And then now we go down that road of, do we need a guardianship? But there again, the guardianship doesn't necessarily solve the mental health crisis or the mental health issue. So, yeah, it's certainly something that could be improved.
And there is a third issue. The third issue is that there's no state registry. So what the catch plans do that our healthcare power of attorney doesn't do is that the catch plans are entered into the WISHIN, which is a health information exchange online database, where the person gives permission for who can access that information, but it is in a statewide database. So if the person gives permission for Caitlin in Greene County to receive that information, even though the person's from Dane County, then Caitlin can pull it up because maybe the person's aunt lives in Greene County. So, so there's some statewide ability to that. The Wisconsin Psychiatric Association has a couple of people who are working on improving the PAD process. We haven't seen legislation yet, but we're watching for it. And it is certainly on NAMI's list of priorities. So you're right, Rick, as usual.
And to be fair, one of the things that we talked about when we presented this at MHAP is you've got voluntary folks, which that's not really so much the pain point in this entire process. It's a lot more of individuals that are severe mental illness folks that are not voluntary, where we're having more issues. So these things are great solutions for people who want to be proactive and part of it voluntarily.
And I'll add to what Sunny says. A lot of people start off voluntary and then become involuntary because of their traumatic experience with the system. So this at least peels away people who initially go, yep, I need some help. And this is the kind of help I need. And if the system is able to produce the sort of help that the person would like, if they do this in partnership with somebody who kind of knows what's available. So it should be a realistic plan. But if the system can produce that, then it keeps trust with the person. And that trust is absolutely essential to helping the person continue with voluntary care.
So moving along on that document.
Yeah.
Thanks, Sita. And just as a group, if at any point in time when you're reviewing this at a later date, if you have more thoughts, please email us. Like this is an open door, just keep it going. Part of the crisis prevention, again, we're looking at, so if they refuse prevention options, right, how do we then educate and work with families more closely to get their buy-in? And how do we get those releases of information where possible so that LEO can kind of step in and assist. Getting more peer specialists, that's one of the things that we really have heard ad nauseum, is that we need more peer specialists, and we do, to help kind of facilitate and be a bridge with folks. Going on under crisis prevention still, we've got inadequate access to prevention. So that's part of not having the peer support. One of the comments that we had from our roundtable discussions at MHAP is that it needs to start in preschool. So that's why you'll see some of the green notes from CETA on there, and having more mental health screenings. Yeah, this document's super long, so we are just kind of skimming along here. More crisis prevention. What we identified very early on is nobody owns this entire process. It's like everybody has, whether it's cops, crisis, corporation counsel, the psychiatric facilities, the hospitals that do med clearance, we all have like a little piece of the pie, but no one person or no one group is in charge of making sure it keeps running efficiently for that person. So we talked about having county case managers. And actually, after I was just at a UWSP crisis intervention conference, and I know our county crisis higher ups were looking at like, yeah, how do we get more of somebody that is tagged to see this person through the process, which is awesome. It's not going to fix everything, but it will certainly help. All right, so then we've got early intervention, right? How do we ensure that Crisis Now model is available through the state, which is someone to call, someone to come, and a safe place to be, essentially. We are part of the problem right now that we identified with this is law enforcement to date are typically the first call always, right? Even if we're trying to divert to 988. I learned an interesting statistic that I do want to share for this, because we love 988. We want to try to divert, but there was a group that I was talking to. They said that out of like 57,000 emergency calls, maybe 38 they identified through their criteria that they could divert to 988, and only 15 of those ended up staying with 988, meaning that remaining of the 38 went back to the police department. So 988 is not this huge, ginormous tool that we can use to divert all these calls necessarily. It's an important tool and one that we should be pursuing, but it's not the answer for everything. So that's part of it. How do we develop more, 24/7 crisis care facilities, develop more crisis teams instead of just law enforcement? So that's their co-response. That's even like your CARES model, where law enforcement isn't even part of it. It's got more peer support involved, fire department, so on and so forth. Go down to the next one, Sita. And this is some more of that, yep, transfer from 911 to 988. I will tell you, because we're looking to implement 988 at our police department's dispatch. It's an MOU. It's very simple. There's not like a lot of liability issues from the city attorney's side. So that's great. Happy to hear it. So meaning it's a very easy switch to make. More early intervention. Person in crisis chooses to go to a crisis stabilization facility voluntarily. That's awesome. But we have lack of having enough beds. Even if the person is voluntary, we don't have enough beds for people in general. So how do we facilitate that better? Also, one of the big comments that we had is family care or IRIS placements. There's some pain points around that. So how do we narrow the LOS criteria for stabilization centers and just get more beds in general started? There was the children's in crisis. Sita, do you remember more about that? I'm forgetting that part.
Hard for me to unmute and share at the same time.
Sorry about that.
Sorry. So there is a program that has been in place for 20 years in Illinois called the SAS program for early intervention for kids in crisis, kids with intensive needs. it came along with legislation called, I think, the Custody Relinquishment Prevention Act. So parents don't have to relinquish custody of their kids simply to get intensive treatment for their kids. And that's been in place for 20 years in Illinois. Wisconsin, the Department of Health Services, Bill Hanna, the Medicaid director, is trying to do a similar program here, and it was brought before the Legislative Committee on Emergency Detention of Minors. And I'm forgetting the bill number. The bill isn't moving very fast, and there's some hesitation on the part of various stakeholders, but it's basically a wraparound model for kids with intensive needs, so that rather than waiting for kids to blow up and end up in, the justice system, they would wrap around the family. Multiple, like Department of Children and Families, Department of Public Instruction, Department of Health and Services, and all the counties working together to help the child and the family.
Yeah.
Okay, back to sharing here. I think I'm going to leave my mic on so that I don't have to.
Perfect.
This technology piece is not my strength. Okay, here we are.
Yeah. Any questions or anything so far? Like I said, at any point in time, please just while we're on it, feedback, anything. All right, so right now we're in the part of the process where law enforcement's getting involved. We've got that initial call to dispatch. So some of the pain points, right? Are all officers CIT trained? Just additional feedback, because I'm a CIT coordinator. We just had a session next week. We were supposed to be training 40 hours for officers in Southeast Wisconsin, and it ended up getting canceled because there's not enough interest in departments sending people. And that's been kind of a common theme this fall throughout Wisconsin. All the different groups that are trying to do NAMI CIT training, they're ending up canceled. So hopefully in spring we'll have more participation, but how do we keep officers that have not had this important training going and getting it?
I'll mention real quick, right now, this week, there is a training going on in Milwaukee. There's 38 officers there.
Mm-hmm. That one was a big one, but there's a lot of other.
Well, there's a lot that aren't, right?
Yeah, we got hacked. Miss Leslie.
I'm curious if that's lack of interest versus lack of cops being able to fill shifts and overtime concerns at departments, as we're all seeing that is still an issue and people are very much understaffed at police departments.
Good point, Leslie. I think a little bit of all that. Yeah. Pete.
Well, yeah, Leslie brought up one of my questions, but also, I've worked in places that if you don't do your additional training, you're kept from certain jobs. And I guess that's my question is, why would this training not be, something that officers have to have, period? There is no, you don't get a choice. It's part of your job.
So I'm not putting anybody on the spot, but we do have some higher level police folks in
Yeah,
this,
I'd love
in
to
this
hear
group
from
that if they want to talk about the challenges as leaders getting their people, but it's like Leslie said, it's overtime, right? If it's a 40-hour, it's an entire week, Pete. So that is, especially for like a smaller department, that can be very draining. Yeah, Ryan, would you please?
Yeah, CIT training is mandatory for my officers. So as soon as we hire someone, as soon as we can get them off field training, or even during field training, if there's a class nearby, we send it to them. But yeah, I would agree with Leslie. I think I have a hard time believing that there's a lack of willingness for departments. In fact, I would think it's probably increasing, but it really comes down to everybody is understaffed or short-staffed. And they probably I can only assume, but they just cannot send people to training right now. Budgets are getting cut or slimmed down. It's getting tough out there. But for my department and all the departments in central Wisconsin, all of our staff are CIT trained.
That's awesome. Because I know, I mean, mostly that's, I think, the status quo around Wisconsin. Not everywhere, but the majority for sure, I would say. Yeah.
So,
What,
mind
how
if I
can
jump
we,
in quickly?
Oh, please do, Emily. Yeah.
Um, so CIT is not required. It is considered a specialty. However, some departments do choose, as Ryan was saying, to have all their officers trained, which is fantastic. However, we at NAMI Wisconsin and then the Wisconsin CIT Advisory Committee and CIT International don't recommend it as a required training because you want officers who are invested in being a CIT officer. And that really want to go through the training and utilize those skills afterwards. I will say that there are so many departments in Wisconsin that are really invested in this, and all of their officers are invested in it, and they are requiring it. But at a statewide level, we don't require it. Officers also currently get 20 hours of mental health education at the academy level in Wisconsin. And then the 40-hour CIT is on top of that, which we totally appreciate. And then beyond that, I just want to mention that, yes, a lot of departments in Wisconsin are fully on board with CIT, and that's really great. However, we only have CIT teams currently in a little over half of the counties in Wisconsin, and we do still get pushback. I work with a lot of places across the state. In areas that CIT doesn't exist, and we still get some pushback from some departments. So it is an interesting thing to see where you get pushback and where you don't. And then the last thing I'll say is that, yeah, if you have any insight into why this fall training numbers are down in law enforcement, please let me know, because I'm looking at Dominique next to me, but that we're very confused on why the training numbers this fall are just gone down significantly. So
thank you.
Thanks.
Yeah.
All right. The only thing I was going to ask is if, budgets and getting people to training, why isn't the training adapted to come to them? That if there is this problem for officers to go get training, then why are we not bringing training to them?
Well, that's a really good question. So the CIT trainings are currently, we follow what is called the Memphis model, which means that they're community-based. That means that the presenters and the experts that are coming and doing presentations at the CIT trainings are from the community. The reason that we do that is because we want not only to have officers get a training when they're at that training, but you also want to build relationships with people who are working in your community. So those mental health providers that's coming in to do a mental illness 101, they might also be an emergency room nurse practitioner, for example. And then when someone's bringing someone in, they already have that relationship with that person. So how do we continue to build the relationships in the community? And that's what the Memphis model is built off of, is a community-based training put on by people in the community. So all of our coordinating teams are from those communities. For us, a community can be a county. It can also be multi-county, right? So you see central Wisconsin's a great example. I think there are 5 counties that are working together because of the population in central Wisconsin and also just the areas that kind of need to be covered there. But you're still getting presenters from all across those 5 counties. And then when you do site visits and when you're learning about community resources, you're learning about the community resources from the different counties and from the areas that you might be drawing from. Does that make sense, Pete? And would a CIT officer or trained person want to talk to that?
It makes sense, but that's in a perfect world. We're not in a perfect world.
Absolutely. And so we have what we call our traveling CIP team, so that we can meet the standards of CIT, but also bring CIP to different areas of the state. CIP is kind of a modified, shorter version. I don't want to take up a bunch of time here, but basically what we do with that training is that we bring that training to places that don't have CIT, and our goal is to not only train officers in the trainings there, but also then, you know, get some buy-in from the department and say, oh, this is a good training. We want to do this more. We want to add more to this. And we haven't seen it work everywhere, but we have had teams been developed based on bringing a traveling CIP to them. So the CIT is harder because there's so many community-based elements to it. But we do try to bring that training to different places in the country. And in the state, sorry. If you have any more questions on that, Pete, I'd be happy to have a conversation about CIT.
Awesome. All right, so going through a little bit more of the charts. Thank you guys, by the way, for the discussion. I'm just keeping my eye on the time. We got to keep a little bit for the rest of our points at the end here, but we've got on-site crisis assessments, right? So how do this is basically the on-site crisis. This is where I talked about it not really being linear. Personally, what I've identified as being a very efficient model is co-response, because that clinician is coming with officers initially when that call is being dispatched. The person in crisis is not telling their story to family and then cops and then crisis and then hospital staff, right, where they're repeating it 5 times. We're really limiting that. So it's more of a trauma-informed response to have that. So how do we just try to get the person to have to explain it less, essentially? If you don't have a co-response, fine, but how do we do less of that? Then we've got the issue of, right, we know workforce shortage, not enough crisis workers. Burnout is real for not only officers, but for clinicians. So how do we get maybe more focused training for social workers? For example, we don't have, when you go to school to be a social worker, there are very few, if any, I think there's some programs that are trying, but there's no program that helps crisis social workers specifically hone in on working with law enforcement. That would be beneficial if they would, because it's going to look a lot different riding with us than if you're just getting a response from your office. Other things is, right, how do we deal with getting evaluations in rural areas? So it's nice if Waukesha City, I got it made. I got all the resources right there. But for our rural crisis calls, everything takes a lot more time. So how do we expedite for them? And what does that look like? Then we've got the transport to the emergency room. Again, not linear. So for some folks, what it looks like is, you know, they've got the PD needs to get to the person to the hospital before that assessment even starts to take place. But for other folks, like for myself, we can do that in the person in crisis's home or on the side of the street. So how do we expedite this? Maybe that looks like using iPads more to do assessments that way. Although I would tell you, and I'm sure the crisis clinicians that are joining us here today would say it's really hard. Like, you want to be able to lay eyes on the person and not just talk to them over the phone, because it's all the things that they're saying. Yes, but it's also the things that you're not seeing. Kendra.
I just wanted to comment on that because there was an incident recently where our crisis worker, I usually have a partner, but he was out that day. And the crisis worker that I called was 40 minutes away. And this was quite a situation where we needed someone to make the assessment. For some reason, my work cell wasn't working, so I used my personal, which was an iPhone, and that crisis worker had an iPhone. So it worked out that we could do that video assessment. And that person didn't want to talk to crisis, and they weren't going to talk to her whether she was in person or on the video. And that was very effective to get that done and for her to authorize the chapter 5115 that was needed in that situation.
Awesome. Yeah. So implement that more. Continuing to look at this. We know, I'm just going to skip. Let's just skip to the med clearance part, Sita. So major issues with med clearance. I'll let you guys kind of look at this, but essentially med clearance issues. Person that's chaptered can say no to med clearance, right? That can turn what would be maybe a 6-hour emergency detention into 24 hours or more. That's a problem. We also know that the psychiatric facilities, there is no standard medical clearance form. One of the things that we've been talking about is a SMART form, for example. That doesn't exist as it is right now. Every psychiatric facility can just keep adding tests willy-nilly, whatever they think that their facility needs. That takes a lot of time. The medical clearance in terms of getting the person. So one of the things that we had, which again, not in Waukesha, thankfully, but I think in more rural areas, is that even though an officer is with this person who's on a 5115, the hospital that's doing the medical clearance is not prioritizing getting that person through the process faster. Just the normal citizens that are walking into the hospital, right? You just fall in queue behind them. Well, this can cause issues where the person becomes very combative. It can lengthen the 5115 process. There's all sorts of things with that. Yeah, moving along with the emergency detention, we've talked about. So if the person refuses to participate in the medical clearance, and we have this 72 hours to get them looked at, sometimes that lapses and it can create a whole issue with just the whole entire 5115 process to begin with. So how do we, one of the things we talked about is how do we allow an extension of that 72-hour hold for the folks who are not cooperating with the med clearance. So let's keep going down. CETA, emergency detention. We've talked about the issues of just 5115 law. How are we defining and utilizing dangerousness? How are we defining and using imminent, right? This criteria is so very narrow. That's not true for all states, but in the state of Wisconsin, this is where we're at. So how do we just look at our law and how the statutes are putting together in order to help basically a broader range of folks? I know Zach had a wonderful discussion on this at that recent conference as well. And so corporation councils are aware of what a struggle this is. Yes, Pete.
Is there any one of the police officers, you know, and I don't know, Ryan being in the position you are, is there any one of you that can define in what is imminent danger?
We're going to let Zach talk about that.
Or Zach, if Zach can define that so that it seems like a subjective, you know, thing. And
yep, let's let Zach.
Yeah, all right. Yeah.
Yep.
Yeah, I mean, you're right, Pete. It is a subjective term. It's not defined anywhere in statute, but generally the consensus among, you know, my colleagues here in Waukesha County and across the state is that imminent means immediate, right? Like we need to take action this exact minute, or if we wait a minute, this is going to happen. So, you know, I know we've previously talked about this, but when you're talking about the person that's not engaging in proper nutrition, there's likely not an imminent risk of substantial physical disability or death until you get to that point, until you watch it happen for a long period of time, and then you hit that point, right? And that's kind of one of the challenges with it, is it needs to be, we almost have to let it take its course for an extended period of time before we hit that imminent period when, like, now we need to take that action or it's going to happen right away, right after if we don't. That's not the clearest definition for you, but immediate is kind of the way that we view it.
Okay, Pete. Yep.
Well, here's my question for you, Zach. My son stood in front of officers face to face, telling them to put a bullet in, and did it in an aggressive manner. But because he was dressed in shorts in my house, that evidently, and again, you'd have to see the tape to help you understand because you're hearing my biased end of it, but I guarantee you After seeing it, I think you'd be pretty disturbed how anybody could say that my son did not need to be in a hospital after watching him repeatedly face to face and have one of the officers start to get aggressive where we had to, whoa, and yet there was no imminent danger apparently.
So long discussion there, Pete, right? We're not going to be able to solve that right now. But I know one of the talking points for our group is who can we invite to the table, this MHAP table, to learn more and have more learning. So I'm Sita.
Yeah, so there's a group of judges, a committee of judges under the administration of the Office of the Courts that is about to take up Chapter 51, and that imminent issue. Judge Davis brought it up when we spoke with her. That imminent issue is kind of hot on their agenda. So it looks like we're interested in this. The judges are interested in this. There are work groups in various parts of the state who are interested in this. So we're all going to do our best to connect the dots and come together and collaborate. And we may get a tipping point on this whole Chapter 51 thing.
Yep. And if we as a group want to hear from Corporation Counsel again, where they present a little bit more about the process, like I said, Zach just had a phenomenal presentation. So if you're willing, Zach, to join, share that with us, that'd be awesome. But he can talk about this more at length during a learning session too. So just because I can see the time, like I said, please work through. Hopefully now you can kind of see how this chart is flowing. But on your own time, take a look. If there's a piece of your pie, so like, for example, when we get to the commitment and settlement portion of this, if Zach is, so I'm going to pick on you, Zach, a little bit more. If Zach's reading through this and is like, oh, that is way whack, that's not right. They're missing A, B, and C, reach out to us. It'll help us get it right. Sita.
And the purpose of this chart is to kind of put the bones together for a report to the Department of Health Services, recommending that they take a detailed look at the Chapter 51 emergency detention and civil commitment process. So the more input we can get into this chart, the better we can do on creating a report, and the more detail, if we can get examples from counties or examples from programs or examples from stakeholders, that'll help a lot as we do this report. And so the report the chart is the beginning. We will finish the report and submit it to the work group for approval in like March-ish, and then submit it to DHS in May of 2026. The idea being that they can then take it and incorporate it into their budget recommendations for 2027.
And the very simplistic thing is if you can't read through it and you're like, yeah, this is just too much. If you have a piece of that 5115 pie, whatever your background is, and you know a pain point, right? The things that are not working, or you think like, no, we're doing it really good here. That's what Sita and I want to hear from you, please. It's as simple as that. So if the chart is too confusing and whatever, that's fine. Just what's working, what's not. So getting back to the main agenda then, Sita, because I know we've got 2 minutes here.
Yeah, we'd like to set up 2 subgroups. One is to formulate a data request to counties for emergency detention. So time and dispensation data. If there are people who would contact me, I'll put, I sent out the email, so you can just contact me and say, yep, I'd like to be on that. We want to get a realistic data request that we can submit to counties and say, this is the data we need in order to be able to give data on the emergency detention process, where it's working less well, where it needs substantial improvement in the state, not to shame any counties or anything like that, but also lift up best practices and look at factors that may be influencing that. And then the second small work group is for a criminal justice learning session for the whole MHAP community. And that will be in January, either January 23rd or February 20th of 2026, both Friday afternoons from 2:30 to 4 on the Chapter 51 emergency detention process, both issues and best practices. We would like to get a panel of folks from communities and counties to speak about what they're doing that is effective because this is this general sense of it's all wrong. And the fact is that counties have developed effective practices, and departments and hospitals have developed effective practices. So we want to lift up what's working and help connect people with each other to learn from each other. And so we need a subgroup for that too. So if you're interested in the learning session, please email me. And then our next work group meeting will be Wednesday, October 8th. We're welcoming Mary Madden, who is the executive director of NAMI Southeast Wisconsin, who was involved from 2009 forward in what Waukesha has now developed a lot of good practices for making this process work as well as it can. So Mary's going to give us some history.
All right. As always, thank you guys so much for joining us today. Grateful to have you. Hopefully we'll get to see you October 8th, but otherwise just email us any kind of feedback that you have regarding that chart. All right. Thank you so much. Bye now.